First of all, it is an honor for me to be with you today among so many remarkable specialists in diabetic neuropathy. The Romanian guide, published in 2020 and revised in 2021, presents current information on this topic. These recommendations are in line with those of other international guidelines, and it encourages orientation with a strong impact on clinical practice. The principal benefit of guidelines is to improve the quality of care received by patients. The Romanian Society of Diabetic Neuropathy was responsible for the introduction into the national guidelines of the recommendation for diabetic neuropathy. Managing people with diabetes and chronic complications requires a holistic, multidisciplinary approach, overcoming the borders between medical fields. Diabetic neuropathy affects 2 out of 3 people diagnosed with diabetes mellitus. And a study conducted by Neurodiab Romania shows that neuropathy and ulceration are present in 15% of the cases, while neuropathy leading to the amputation of lower limbs is present in 4% of the cases. The early diagnosis of the signs of diabetic neuropathy is extremely important in order to prevent its complication and reduce the risk of amputation. The recommendation of the Romanian guide show that all patients should be assessed for diabetic peripheral neuropathy, starting with diagnosis of type 2 diabetes and 5 years after the diagnosis of type 1 diabetes, and at least annually thereafter. Symptoms and signs of autonomic neuropathy should be assessed in patients with microvascular complications. The diagnosis of peripheral neuropathy is made on the basis of the case, history, physical examination, and differential diagnosis. The management of diabetic neuropathy is patient-centered as it is recommended by the international guidelines, which are to be found in the Romanian guidelines as well. This recommendation concerns non-pharmacological and pharmacological treatment. For the first time, the Romanian Management Guide for Diabetes mellitus specifies that the ethiopathogenic treatment recommends the use of alpha-lipoic acid with antioxidant potential and of benfotiamine. The benefits of a treatment associating alpha-lipoic acid and benfotiamine are also underlined. This is a new recommendation which has just been introduced and constitutes a change of paradigm in the approach to diabetic neuropathy. We are the ones who have changed the recommendation of the guide regarding the management of diabetic neuropathy by recommending alpha-lipoic acid together with benfotiamine as the ethiopathogenic treatment of diabetic neuropathy. The symptomatic treatment of neuropathic pain is also mentioned, including antidepressants, anticonvulsivants, opioids, or capsaicin patch. In conclusion, the Romanian guidelines created by Romanian Society of Diabetic Neuropathy is primarily addressed to health professionals, yet it also includes recommendations for people with diabetic neuropathy. Now there are clear recommendations regarding the screening, diagnosis, and treatment of diabetic neuropathy. The impact of the guide in clinical practice will lead to a decrease in the complication of diabetic neuropathy and an increase in the quality of life for people with diabetic neuropathy. We move on to this international expert consensus recommendation regarding screening, diagnosis, and management of diabetic sensory-motor polyneuropathy in clinical practice. In this consensus recommendation, the first part is screening. Patient history should encompass neuropathic pain characteristics, assessment of pain severity, and interference with daily activities and sleep. Patient history should encompass non-painful symptoms like paresthesias, numbness, sensory distortion, and for screening or identification of neuropathic pain characteristics, appropriate questionnaires such as DM4 may be used. And for clinical diagnosis of diabetic neuropathy in practice, validated scores for neuropathic symptoms and signs may be used. Clinical diagnosis is also very important. Bilateral impairment of vibration sensation with tuning fork for large fibers and or pinprick test for small fibers may be appropriate as minimal criteria for diagnosis of diabetic neuropathy in clinical practice. The presence of neuropathic pain and signs for diabetes neuropathy in the same distribution is suggestive of painful diabetic neuropathy. A single abnormal screening test bilaterally suggests the presence of diabetic neuropathy and may require a more extended diagnostic workup. Consider other causes of polyneuropathy like drug induced by history, but in the same time, assessment of vitamin B12, serum protein electrophoresis, eGFR, TSH, blood count, magnesium, and liver enzymes may be advisable. In addition, assessment of vitamin D status may be advisable. Pharmacotherapy of diabetic neuropathy. Pathogenetically oriented pharmacotherapy. Alpha-lipoic acid and benfotiamine have been approved for the treatment of symptomatic diabetic neuropathy in several countries, but not by FDA and AMA. Pathogenetically oriented treatment with alpha-lipoic acid and benfotiamine may be used for the treatment of symptomatic diabetic neuropathy where available. Pathogenetically oriented treatment with alpha-lipoic acid may also be used for the treatment of neuropathic deficit where available. And the evidence for alpha-lipoic acid is stronger than for benfotiamine. For treatment for painful in diabetic neuropathy, gabapentin or pregabalin are considered the first-line analgesic treatment. Titration is usually more convenient with pregabalin compared to gabapentin. Also, in the first-line analgesic treatment for painful are duloxetine and amitriptyline. Doses used in the treatment of painful diabetic neuropathy are usually lower than in depressive patients. The second-line analgesic treatment for painful in diabetic neuropathy, tramadol is considered. If tramadol is not available or effective, oxycodone or tapentadol could be an option. Other strong opioids might be used depending on the experience of the physician. The third-line analgesic treatment for painful in this consensus recommendation are strong opioids, but here risk for abuse, issue, dependence, and tolerance should be assessed at the start of treatment and regularly during follow-up. And any treatment longer than 3 months should be regularly re-evaluated. Also, in the third-line analgesic treatment for painful, it's capsaicin patch or capsaicin cream, which may be used in the treatment of painful diabetic neuropathy in clinical practice. In clinical practice, different treatment approaches may be combined. Possible combinations include a mix of different analgesic treatments, mainly antidepressants with gabapentinoids, or combination with opioids as third choice, analgesic plus pathogenetically oriented treatment, mainly antidepressants or gabapentinoids, plus alpha-lipoic acid or benfotiamine, as well as a mix of different pathogenetically oriented treatments, mainly alpha-lipoic acid plus benfotiamine. There is limited evidence in support of analgesics combination compared to monotherapy. Also, evidence supporting the efficacy of non-pharmacological treatments in diabetes sensory-motor polyneuropathy is limited. In conclusion, diabetic sensory-motor polyneuropathy remains poorly diagnosed and treated in spite of the many advances made in the last decade in understanding the pathophysiology of the condition. Reducing the burden of the disease can be done by strategies of early detection and prevention in national diabetes plans or programs. Efficacy of current treatments is limited, therefore, optimizing the therapeutic armamentarium remains an unmet medical need. Due to often inclusive evidence or intervention derived from systematic reviews, a constant need remains for harmonizing and updating of treatment algorithms. And at final, we can say that the Romanian Society of Diabetic Neuropathy as a society of professionals based on the recommendation of the guide promotes an ethical approach means to increase the quality of care for people with diabetic neuropathy. Thank you very much for your attention.